Get it shared. Hopefully you've got a slideshow now.
Yes, thank you.
Okay. So yeah, so this is a bit of a run through. It's not double chambered right ventricle and Ebstein's. That's because I've not changed the title of a previous talk, so I've taken out the slides with double chambered right ventricle. So this is just on Ebstein's anomaly, and then Steffi, our fellow, has got a case, a recent case, just to go through as well. So I usually give this talk to a group of cardiology trainees. So there's a few kind of questions in here, but we'll skip through those because the first thing I ask them to do is draw a simple diagram of Ebstein. So if anyone wants to test themselves, I won't make you turn your cameras on and show them later. See if you can draw yourself an Ebstein's anomaly, and we normally give people a bonus point for illustrating why patients with Ebstein's might have cyanosis. So have a think about that whilst I'm chatting. But this is the man himself. This is Ebstein, who was Polish, trained in Berlin, quite a prolific academic with nearly 300 papers, but actually only 12 of those were cardiovascular, and his description of Ebstein's was almost overlooked, even though that's what he's obviously now most well known for. And his original description of the condition was in a 19-year-old who died, on whom he performed an autopsy, and this 19-year-old was described as emaciated, profoundly cyanosed, with marked jugular venous pulsations synchronous with the heartbeat. So just a little bit about the tricuspid valve to start with. In terms of its development, the leaflets and the tensile apparatus delaminate from the muscular atrioventricular septum. That's how it comes to being. And there are anterior, posterior or inferior and septal leaflets. And if you're a surgeon looking down at the operating table on at the tricuspid valve, you'll see the three leaflets in this position. So you're superior here because you've got the SVC with a cannula in and the IVC with a cannula in, and this is what you're looking. So you'll see a large anterior leaflet here. This is the largest of the three leaflets. A posterior leaflet here, which has a number of scallops, and then a septal leaflet here. There are a number of caudal attachments. I won't go into the detail. It doesn't really matter about what attaches where, but there's obviously a number of caudal attachments to some papillary muscles within the right ventricle. But there is also direct attachments of the septal wall rather than through a papillary muscle. The caudal attachments are direct to the septal and anterior leaflets from the septal wall. And you can have accessory cords attaching to the RV-free wall and in fact the moderator band. And all of these kind of multiple caudal attachments can be important in sort of causing sort of functional TR when the RV becomes dilated and dysfunctional. The annulus, this is the shape of it, is a non-planar elliptical in shape. So its posterior septal portion is nearer the RV than its anteroseptal portion. And it's actually very dynamic, so it varies in shape markedly with loading conditions. So even in normal atrial systole, its circumference reduces by about 20% and its area by about 30%. And the septal portion of the annulus is actually relatively fixed, and so that portion of it doesn't tend to dilate as the RV dilates. And that means that if you see annular dilatation or tricuspid annular dilatation, that's mainly in its mural aspect, the anterior and posterior aspects. And that, of course, leads to a reduction in leaflet coaption. And when you've got functional TR, the annulus becomes more planar and more circular. So tricuspid valve function will depend quite a lot on intravascular volume and RV function. I seem to have an inability to move on. If anyone can hear me, my computer's stopped. There we go. Okay, there we go. Can people still hear me?
Yeah, I can still hear you.
Yeah.
Oh, sorry, I had a bit of a thing. So Ebstein's is this. So it's a mixture of abnormalities. It's not simply just a little bit of apical displacement of the tricuspid valve, which is perhaps what most people know about Ebstein's. So there's adherence of the septal and posterior leaflets to the underlying myocardium. So remember, we said that it forms by delaminating from the myocardium. So that's a failure of delamination, effectively the development of those leaflets. And then the anterior leaflet has lots of redundancy, may have fenestrations and may be tethered, and may have short and poorly formed chordae. And then there's this downward or apical displacement of the functional annulus. So in the normal heart, the septal and posterior leaflets are apically displaced relative to the anterior mitral valve leaflet, but that displacement shouldn't be any greater than 8 millimeters. So in Ebstein's, it's greater than that. And as a result of that, you have dilatation of what's called an atrialized portion of the right ventricle. I'll show you some pictures of this with various degrees of hypertrophy and thinning of the wall. And you get dilatation of the right AV junction, i.e. the true tricuspid annulus, and that's demarcated anatomically by the right coronary artery. So hopefully this will give you a better idea. So here's a pathological specimens of a heart. So this is a 67-year-old with Ebstein's, and compare that to a normal heart. And then you can see here's a heart that's been dissected. And so here you have the true right atrium. And here you have what would be the normal tricuspid valve annulus. But in fact, here's the tricuspid valve. So this is the right ventricle, and you can see this sort of failure of delamination and tethering here. And then this is the atrialized right ventricle. So this is right ventricular myocardium, but effectively functionally is part of the atrium. And in 2/3 of cases of Ebstein's, the right ventricle is dilated, and that's often not just the atrialized, it's not just this bit, but also the apex and the outlet portions can be dilated as well. So here's an MRI scan just to kind of, again, illustrate that principle of native and functional atria. So here you have the native right atrium, and here you have the atrialized right ventricle, and all of that together then becomes a functional right atrium, with this smaller section here being the functional right ventricle. You can see the displacement. They've sort of measured the displacement of the valve apically there. So what effect does that have on cardiac function? Well, the RV is often impaired, and tricuspid regurgitation means that you have a reduction, and both of those things mean you have a reduction in forward flow out towards the lungs. In atrial systole, that atrialized portion of the right ventricle will balloon out, so it acts as a kind of passive reservoir. The right atrium dilates, and then you get sort of secondary annular dilatation that further increases tricuspid regurgitation. And you can get mobile anterior tricuspid valve leaflet tissue in the RVOT, the outflow tract, which can cause obstruction to outflow. And so the clinical features of Ebstein's, unsurprisingly, are impaired exercise capacity, right heart failure. I'll talk a little bit more about arrhythmia. There is an incidence, a small incidence of sudden cardiac death and cyanosis, which I'll talk about as well. And then clinically, I suppose the usual sign of tricuspid regurgitation is CV waves in the JVP, but actually you might not see them because effectively it's kind of lost in this enormous right atrium. So the next question we often ask trainees is why a patient might be cyanosed. And that's because it's very common to have an interatrial communication in Ebstein's. So it's reported with a varying incidence between 25 and almost 100% of cases. And that potentially allows, obviously, shunting through the atrial septum, and given that all the problems in the right heart, often right to left shunting. And that right to left shunting itself potentially causes systemic desaturation, which itself reduces exercise capacity. And leaves patients at risk of paradoxical embolus or brain abscess. So there might be a little bit of debate about whether you automatically close an atrial septal defect or a PFO, an interatrial communication, because the potential concern is that this acts as a kind of pop-off relief for the right heart. And so if you close that, then you don't allow that anymore, and you force blood through the right heart, so you potentially worsen right ventricular volume overload and TR, which could cause worsened systemic venous congestion and potentially reduce cardiac output, although potentially, of course, this right to left shunt helps to augment the cardiac output at the expense of cyanosis. There's not much data out there on this. I think I have to say I haven't looked for a year or two now, but this was the last paper I could see of a group who'd done 9 device closures in 9 desaturated Epstein patients that they described as mild to moderate in severity, and then followed them for 5 years. 3 of those patients had had a stroke in the past, an ischemic stroke, which is not at all uncommon because of that risk of paradoxical embolus. And so what they do is they occluded the interatrial communication with a balloon for 15 minutes, just to double check that there wasn't a too deleterious effect on the right atrial pressure by doing that. They closed them all, and in just one of those 9 patients developed sort of worsened right-sided heart failure and needed some diuretics, but only for 3 months. And all patients reported feeling that their exercise tolerance was better. The kind of conventional wisdom on here seems to be that you can do it when Epstein's is not too bad, but if there's very severe TR or worse Epstein's, it's probably not the right thing to do, because you're more likely to cause right heart failure. That said, we have done that a few times, and here's an example of a 50-year-old, and you can see here Epstein's echo. You can see the apical displacement of the tricuspid valve, and you can see the very severe jet of tricuspid regurgitation. So she had pretty limited exercise capacity. She had gout, which was related to her systemic desaturation. SATs were 90% at rest and 71% on exercise. And she had flow through, a bidirectional flow through an interatrial communication. So she's got pretty bad Epstein's with pretty severe TR, but we made a decision to close her interatrial communication, and that did improve her symptomatically. It didn't put her into heart failure, it just made her exercise tolerance better. And then you can see, sorry, down here, the right to left flow, or the element of right to left flow through that interatrial communication. She then later, a few years later, did go on to have a tricuspid valve replacement. It wasn't possible intraoperatively to repair that valve. The atrialized right ventricle was plicated. She came off bypass, incomplete heart block, so needed an epicardial pacemaker. And it has done pretty well, actually, to be honest. I think there's been a definite symptomatic improvement in her. In terms of atrial arrhythmia, the basic rule here is that if there's a form of atrial arrhythmia, you can get it with Epstein's. So about a third of them have accessory pathways, usually on the right side. And for various reasons, which I won't go into for this audience, they're actually potentially relatively challenging to ablate compared to usual accessory pathways. And you can see, it's a paper here looking at 32 Epstein patients who underwent catheter ablation, and they found lots of accessory pathways causing AV re-entry tachycardias. They found 8 interatrial re-entry tachycardias, 5 fairly standard flutters, a couple of focal atrial tachycardias, and 1 AV NRT, and potentially these patients can go on, obviously, to develop AF, particularly over time. Right bundle branch block is common in Epstein's because the right bundle is abnormal or becomes fibrosed over time. And in fact, if it's absent, that may indicate that there is an accessory pathway. This is a bit more on arrhythmia. So 79 Epstein patients with a mean age of 37, so not really that old, followed for just over 3 years, and a fifth of them developed new atrial arrhythmia over that period of time in a relatively young cohort. 13% atrial tachycardia is 9% AF. And in fact, 15% develop new VT, 4 sustained, 11 non-sustained. So ventricular arrhythmia is the other element of arrhythmia that they're prone to. It's always important to put your most extreme examples of any condition in a talk. So it's difficult to beat this for Epstein's. Look at this chest X-ray here, this enormous cardiomegaly seen on a scan here, grossly dilated right heart. And this is echo, and of course, what you've got here is a tricuspid valve, severe regurgitation, and you can see just how little the left heart looks in relation to the right in this patient. So can you fix Epstein's? The answer is you can fix it, but technically it's not easy to do so. It's challenging surgery. Tricuspid valve replacement is potentially an option, and you've seen one case already in which we've done that. The concern about tricuspid valve replacement is that in some patients, replaced tricuspid valves don't last very long. Sometimes really they really don't last very long, and they can fail quite quickly. So you try and avoid replacing the tricuspid valve if you can. The other aspect in terms of trying to decide when to operate on a patient with Epstein's is that symptoms can be relatively minimal for quite particularly in younger patients, despite quite severe abnormalities and severe tricuspid regurgitation. So you're in the game of trying to judge taking someone with minimal symptoms with technically demanding surgery, and trying to judge whether that's going to be better for them in the long run and worth the short-term risks and the risks of putting a tricuspid valve replacement in that might not last very long. So it's difficult to predict prognosis or the incidence of right heart failure, although of course what we do know is that as patients get older, then we see them run into more and more problems. And the RV has a very long-standing severe tricuspid regurgitation and may not cope well with surgery. And as soon as you make that tricuspid valve competent, it's only got one way to go potentially, and that's out towards the lungs, which suddenly is quite a hard job, as opposed to just allowing it to regurgitate back towards the right atrium. And of course, some patients may do perfectly fine without anything being done. So this is a patient who's 73. I haven't updated this talk for maybe a year or two, so she's 74 or 75 now. So Epstein's with an interatrial communication, severe tricuspid regurgitation and a pacemaker, having episodes of atrial tachycardia and non-sustained VT. She's fully saturated at rest, but when she walks, she desaturates to the high 80s. She has had a TIA in the past and is anticoagulated, and she has gout. She was told when she was 38 that she would die. I can't remember when she said what her date of death would be, but she was told that she wouldn't live much longer when she was in her 30s. We had a lot of discussion about her, but did actually offer her surgery in her late 60s, and she decided against that, which was probably no bad thing. And she's also decided against having her atrial shunt closed. So in terms of surgical technique, the main operation that's used to try and repair the tricuspid valve in Epstein's is this thing called the cone repair. And in this, you take the anterior and posterior leaflets and potentially the septal leaflet if you can. You completely detach them, rotate them around, and then reattach them. And effectively that then forms this cone with the vertex pointing towards the right ventricular apex. And then the base of that cone is sutured at the true tricuspid valve annulus. So you've taken a valve that's sort of sitting down here, taken it all off completely, rehashed it, twiddled it round a little bit, and then stitched it back to kind of where it should have been in the first place. And the Mayo have published their outcomes from Epstein surgery. So all of their adult Epsteins that they operated on 2007 to 2015 who had exercise tests before and after. So that was actually a relatively small proportion, about 10% of the total patient population. Age between 18 and 64, mean age of 40. 19 of those patients had the cone repair I've just described. 13 had a tricuspid valve replacement. In a quarter, that was redo surgery, and they found that 75% of their patients were symptomatic from their Epstein's prior to the surgery. About half of them had a Mays procedure, so atrial arrhythmia surgery, and 45% of them had closure of an intra-atrial communication. So they felt that in their hands, surgically, technically, was effective in nearly all cases. So pre-op, 77% of them had severe tricuspid regurgitation, and then post-op, more than 90% had no or mild tricuspid regurgitation. And that was a fairly durable change at a year. So they technically fixed the TR. RV function seemed to reduce slightly early post-op and was a little better at a year. And then in terms of the effect on the patients, you can see the chart here shows functional class. So blue before, green afterwards. So you can see all of the class 3 patients have shifted down to a lower class. And you're basically improving NYHA class quite consistently. And 50%, about half, reported improvement in their symptoms. But they didn't find there was any change in that population. They didn't find there was any change in measured exercise capacity, even in those with pre-op desaturation. That's not the only study out there. Other studies have found improvement of exercise capacity, and it may be that they had sort of younger cohorts. And then in another study, unoperated patients show a progressive decline in exercise capacity, as you kind of expect, really, over time, whereas operated patients didn't. So even if you're not improving patient symptoms when you do tricuspid valve surgery, I suppose there potentially is an argument to say that you might be preventing a further decline or keeping people at least at a similar level. The other thing that we think about in Epstein's, in those who have surgery, is doing what's called a Glenn shunt. And effectively, this means disconnecting the SVC from the right atrium and plumbing it directly into the right pulmonary artery. And so that just means that some of the flow, you often have to have low pulmonary artery pressures for this to work. So you check that before the operation. But that means there's just less for the right heart to have to cope with once the valve has been repaired. So it can just help with getting it through the early post-op period, particularly and potentially in the long run as well. So the summary of that is that Epstein's causes obviously severe tricuspid regurgitation, ultimately causes right heart failure, lots of arrhythmia. It's a condition which is associated with cyanosis through right to left shunting through the atrial septum, and is technically challenging to repair. And unfortunately, outcomes from tricuspid valve replacement are not always good and are frequently not good. But it is something we, and I don't, potentially other centres, we've certainly, I think our surgeons have developed a fair amount more experience with repairing the tricuspid valve in Epstein's over the past few years. And so I think our threshold for operating has come down recently. And I think that's not.
Thank you, Jane.
Anyone want to ask anything, or do you want Steffi to do her?
I was just going to ask about pregnancy risk. Does it depend on the size of the right atrium, or?
I think it depends on overall functional capacity is important. I suppose one of the things to remember is, if you've got a patient who's cyanosed, that's that would be a particular worry potentially before pregnancy, both in terms of if you're significantly cyanosed, then there may be an issue about fetal viability in the longer run, so that would need to be dealt with. And then potentially, obviously, there's a risk of paradoxical embolus if there is an intra-atrial communication. That's another thing to think about. Potentially, and we can get around that if they're not too desaturated. There'll be an argument for having someone fully anticoagulated during pregnancy. If someone's functionally, we obviously assess them before pregnancy. If they've got good functional capacity, and there's not, then one would generally expect them to cope pretty well with pregnancy. So exercise tests before measuring saturations and things.
The only other thing just to mention is that there's a potential percutaneous tricuspid valve being developed at the moment as well, which might be suitable for use in Epstein. So it's not really designed for use in Epstein's, but it's the way it's engineered, it potentially may have potential for use in Epstein's patients, and that might give us quite a lot more utility. So we're always concerned about the effect of surgery on the right ventricle because they always look pretty sad afterwards, and some of that's going to be related to bypass issues. So a percutaneous option is good, but that's a kind of watch this space really.
Yeah. I suppose the other thing to say is, although I talked about tricuspid valve replacements not always being good, there's an increasingly percutaneous revalving of a tricuspid valve replacement is possible, and actually there's some pretty good data about the durability of that. That's potentially reduces our threshold and reduces our worry for replacing the tricuspid valve. But clearly, if you're still very young and you have a failing tricuspid valve replacement, there's probably only so many you can have over time.
Anybody got any more questions, or shall we move on to Steffi?
Looks like Steph is there.